Action. Start. Good evening, everyone. I am Rotarian Biswajit Banerjee, and I have known Dr. Subrahmanyam, aka Subbu, since the past 12 years. Am I right? 12 years?
Seems like more.
Seems like. Welcome, Dr. Maddirala Subrahmanyam, to Coffee with Rotarians. Well, my first question to you. So, Subbu, how did you become an anesthesiologist?
Okay. So actually, it's by accident, I should say. First of all, it's a very long road being a doctor. In my medical school, in my school, sorry, I was in HPS Ramantapur and CBSE syllabus. So the 11th and 12th, we had an opportunity to take MPBC, Maths, Physics, Biology, Chemistry. So you could quit one language. So though I am Telugu, I was not very good at reading, writing Telugu. So to avoid Telugu, I took biology. So I was maths interested, and I also got a seat in BITS Pilani. So this was in 1980. At that time, when you get into BITS Pilani, there was no, you couldn't decide what engineering seat you got. You just get in, and depending on how you did in the first year, they would allocate your branch, or you could choose. Then my father said, what, you'll be doing a job with somebody, it's not, why don't you be a doctor? So I said, okay, and I didn't know anything at that time. And after 12th was over, I went 1 month to Ravi tutorial in Guntur, because CBSE, everyone said you won't pass the entrance. So that 1 month in Ravi tutorial, God was very kind, I got into Usmania Medical College. So that is 5 years of medicine, 1 year of internship. Then again, I studied and wrote for the entrance here. That time, the national entrance was not there. So we had entrance in Andhra Pradesh. So I got, depending on your rank, I didn't get a great rank. So I had to take a diploma in anesthesia. Diploma is a 2-year course. So it's not as valued as an MD, which is a 3-year course. So while doing that diploma in Usmania, some friends I knew were in PGI Chandigarh. They said, you'll have a good chance. There are some 9 seats this year, all over India, that is. According to them, that was very unusually large. So you apply, and since you are already in anesthesia, you will have a good chance. So I applied, and again, I was fortunate to get in. So that was 3 years. After that, I did 2 more years of work there. And then I went to UK for some time, US for some time, and I came back in 2000. So took about 10 years of training to become a well-rounded anesthesiologist.
Okay, so you put people to sleep.
Yeah, I wake them up also. I keep telling everybody that. So if I just put people to sleep and don't wake them up, I'll be in jail by now.
So, what other roles do anesthesia doctors have?
So a lot of people don't know that apart from actually doing anesthesia in theaters, which is for surgery. I mean, this is the common role everybody knows, that without an anesthetist, you can't have a surgery. But we also do, like, if you must have heard the word code blue. I mean, you are asking me to do a resuscitation course. So code blue is if any patient crashes in a hospital, he either stops breathing or his heart stops or collapses. So there is a resuscitation team, and the main member of that team is an anesthesiologist, because we have good skills at those patients need to be put on a ventilator, and you have to massage, increase their blood pressure, do a lot of things which typically an anesthesiologist anyway is doing. Then critical care is another aspect which we take care of patients in intensive care, putting them on ventilator, managing, how much breaths to give, when to take them off the ventilator. One more role is sedation, and like for example, some child needs endoscopy, they need an MRI, they need a CT scan, they won't tolerate, I mean, just to lie still. See, in MRI and CT scan, you don't need pain relief. You just need to lie still. But children won't lie still. And adults sometimes are, I don't know how many of you got an MRI here. So there's something called claustrophobia. When you go into that, MRI is like a cave. You go into it. So I know some VIPs who had anesthesia to get MRI done. It's just a scary thing to go into that vault-like thing. Then if you need endoscopy, just it's a very short procedure, but very uncomfortable. So you need anesthesia for that. Then one other big area is now labor. I sort of pioneered labor analgesia in Hyderabad. You need women go through labor, all of us know, and it's very painful. Those all women here will know. It's especially the first time, it's 8 to 10 hours of labor and intensely painful. So now we have very good techniques like this epidural and other things where a woman can be very comfortable and have a normal delivery without this discomfort. So very few hospitals even today do it fully, but when I started, it was not even heard of. So all these areas are, accessory to us around anesthesia.
So anesthesia has become very easy. Like it's easy for the patient. But there was a time, I think, in olden days, they used to give whiskey or something
Yes,
and
you're
hit them on the
absolutely right.
head. Huh? No,
No, but
before chloroform.
yeah, so everything came in 1840s. Okay. The first successful demonstration of anesthesia was in Harvard when ether was demonstrated for a thyroid procedure. So someone needed a thyroidectomy. So ether, ether is, so you just put drops on a mask
Drops.
and it evaporates. So you breathe in that vapor. So ether is very volatile. So if you just put ether and it will vaporize in the air. So, but it was a very uncertain science. People used to get unconscious. The depth of anesthesia couldn't be controlled. So there were a lot of deaths with that. But anyway, that was the first successful anesthetic in 1830 something. I don't remember the exact date. So that place is still preserved in Harvard University. It's Harvard Medical School. It's called Ether Dome. So after that, you had a pain-free way of giving anesthesia and doing surgery. So today there are surgeries which last sometimes 12 hours, 14 hours, 16 hours. So there's no end point. Surgeons do all kinds of things because they know that there's somebody there to take care of the patient. So once a patient is asleep, you have to monitor their heart, their blood pressure, their respiration, their oxygenation, their unconsciousness, because if they are aware of something going on, it's very distressing. So all these things you have to do, and their electrolyte levels, if they're losing blood, you have to replace blood, you have to give fluids, you have to ensure that their urine output is good. So all these parameters which a normal person does, you have to monitor during anesthesia, and that length can vary depending on the kind of surgery. Like, I mean, typically the long surgeries are reconstructive. Somebody has hand got cut off, for example. So you attach. You must have seen in movies or TV shows. Today, if somebody has an amputation, it's called either road accident or in machines, agriculture machines, which have those threshers and all. Sometimes your finger or hand can get cut. Punjab, it used to happen a lot when I was in Chandigarh. So they'll just wrap that up and bring, but ideally you should wrap it in ice so that the limb doesn't get damaged. And artery to artery, nerve to nerve, they'll use a microscope and it'll take 12 hours, 18 hours to connect it
Very
together.
structured.
Yeah. Transplant surgery, liver transplant takes about 12 hours, the surgery. Some neurosurgeries take 12 hours, 16 hours. So there are a lot of surgeries which take, today time is not the matter. I mean, it's only as long as you can maintain the safety of patient, time is, so it all depends on how sick the patient is and whether they'll tolerate that length of surgery.
All right. And how has anesthesia progressed over the years?
Yeah, good question. So as I said, initially anesthesia was ether or chloroform, and it had a lot of side effects like nausea and they were unconscious for a long period of time. So you couldn't predict the depth and monitor it properly. So the first thing which made anesthesia safer, I would say, is monitoring. So what you routinely today, you have pulse oximeter. COVID made pulse oximeter common to everybody, but that was not there till about 1980s in India. When I was doing anesthesia, it freshly came. So then when you're breathing, you breathe out carbon dioxide, you breathe in oxygen. So depending on how much carbon dioxide you're breathing, you'll know whether your respiration is adequate or not. So there is a monitor which can measure your carbon dioxide.
Okay.
So all these monitors add to your safety. So there are some other gases today like chloroform, which are called sevoflurane, isoflurane, which are much safer. They are used to keep you unconscious. So how much is the concentration of that gas is also there on a monitor. Your blood pressure is there on a monitor. Now in some cases where you anticipate a lot of blood loss, like major neurosurgeries or transplants, this blood pressure, you have automated blood pressures, like they'll measure once in 3 minutes, once in 5 minutes, you can set the time. But that also may be too much time for me. Okay, so we put a small needle into the artery, like an IV cannula. Instead of putting the cannula in the vein, we put one cannula in the artery, and every beat you get the blood pressure. So it's called invasive arterial pressure. So we do that when some patients are sicker and you need to monitor their blood pressure very closely. So especially if somebody's heart is very weak and we need to make sure that their blood pressure is kept stable, or patients in intensive care who are sick and who are on medicines which are keeping up their blood pressure. So in a lot of instances we do this monitoring. Then there is something else called central venous monitoring. So normally this IV cannulas, you can't take blood out, or nor can you give blood very fast. So this internal jugular vein, it's called, it's quite big. So you can put a large bore cannula. We do all this when patients are asleep typically. So you put a big cannula here, then you can give lot of blood and fluids rapidly, where you anticipate, sudden changes. Now some vascular surgeries are there. Somebody may have an aneurysm of the aorta. So suddenly you lose a liter of blood. So then you have to transfuse that amount of blood suddenly, and your normal IV, how much ever you push, you can't push that much inside. So you have this larger veins. So all these are skills and monitors anesthesiologists use.
But this seems very dangerous. How do you ensure the safety of the patient?
That's what I said. So all these monitors, the beauty is you can set alarm limits. So for example, blood pressure. So I can set a limit that if patient's blood pressure falls below, normally blood pressure is 120/80. So let's say I'll tolerate till 90, the upper one coming till 90. So I can set a limit there that if the blood pressure is below 90, it will beep, a loud beep will come. Likewise, if oxygen saturation I'm measuring, that pulse oximetry, if it comes below 90, I can set whatever limit and it will beep. So now let's say patient is on a ventilator. Typically we call it anesthesia machine in the operation theatre. In intensive care, that same thing is called a ventilator. So under general anesthesia, there are different types of anesthesia, maybe that can be covered later. But under general anesthesia, patient is unconscious. Sometimes they are not even breathing. So in that instance, we put a tube in their trachea, that is their windpipe, and we connect it to a ventilator equivalent anesthesia machine, through which we give controlled gases and this anesthetic gas, other things. So supposing that disconnects and you don't see it for 2-3 minutes, patient can die. I mean, if you don't get oxygen for 2-3 minutes, you'll die. So that respiratory rate, carbon dioxide, so there'll be a monitor which will start beeping if the carbon dioxide trace, because when you breathe out, carbon dioxide comes out. So all these monitors enhance safety. Okay, so that's one way of ensuring safety is by having adequate monitoring. which again also increases cost of the whole procedure, because the more sophisticated a monitor, the more expensive, and hospital needs multiple monitors, not only during anesthesia. When they wake up also for 2-3 hours, you need to monitor that they are safe.
Okay. So then what are the types of anesthesia you are using?
Okay.
Types.
Yeah, again, good question. So broadly, one is general anesthesia, the other is called regional anesthesia. So regional means one part. Now, if there is a surgery here, instead of doing full general anesthesia, if there's a way I can only anesthetize the arm, we can do it. So typically that is by blocking a nerve. So I can block a nerve which supplies this hand, and there are ways of identifying that nerve using an ultrasound, or there are, you use a machine which when it close to a nerve, you'll get a jerk.
Okay.
So those ways you can know you're close to the nerve you want and give that local anesthetic. It will numb, just like a dentist gives for numbing your tooth, you numb a nerve. Second is what is called spinal anesthesia. So you give in the back an injection which numbs the whole body below that area. And a third is you just need sedation to tolerate some procedures. So it's not even anesthesia, not even regional. Like for example, MRI, now what I was talking about. If some adult person needs an MRI, all I need is they should be asleep. So you don't need full anesthesia. So I just give a sedative drug and monitor.
Okay.
Ensure that, he's not aware of what is
Aware
happening.
of, okay. Feels comfortable.
Yeah. More or less, yeah. Regional means one region, local means just that point. So,
More specific.
supposing you're removing a small thing, you just, if you infiltrate the skin, that 1 inch or 2 inches will become numb. So, but if you have to fix a fracture or something, that 2 inches won't work. So, you have to anesthetize the whole hand. But again, all this, the choice depends on the kinds of patients. Like children will not tolerate this, he won't let you give a block in the hand or something. So either you first sedate him, when he or she is asleep, you do that. Okay. So a lot of adults also may not cooperate. So it all depends on which patients allow what kind of thing.
Subbu, what are some of your scariest moments and which kind of cases have been most challenging?
Yeah. So see, anesthesia is by and large become very safe, but depending on patient diseases. So let's say someone has had a heart attack and his heart is very weak. So heart attack means some blood vessel to some part of the heart got blocked. Either he's then had a stent or whatever, but supposing the heart is not pumping as well as it should. Normally when a heart pumps, if there's 100 ml of blood in the heart, if it pumps, 60 ml should go out. So we call that a ejection fraction. So 60% is good and normal. If it's less than 45, 40, it's bad. Okay, so what happens is, if heart is not pumping blood, there's no oxygen coming to the whole of your body. So you get breathless very soon. The organs won't tolerate that. So there are a lot of conditions where the heart becomes weak, either because the heart is bad or lungs are bad or you've had a heart attack. So if this kind of patients come to us, then and they need some anesthesia, we have to be on our toes. We put all this arterial line, we have to give medicines to increase blood pressure. Then we warn them that there is a chance that you will have a morbidity or a mortality. So morbidity means some complication, mortality means death. So nobody likes to hear that they'll die. So you have to, again, the way you say it, you have to say it in a very, you shouldn't make the patient run away from you. At the same time, you make them understand that they're not normal. So as a common parlance, what I tell is, today if I have to drive from here to Vijayawada, I get a new Mercedes Benz, I know I'll be safe. But if you give me a 20-year-old Fiat and it has one puncture somewhere, it has one old gearbox, how will I go safely till there? So I may go if I'm a good driver, but the chance that it will happen is much lower than the other car. So that's exactly what it is. And, it's all a percentage. People ask, what is the risk in, if this kind of patient comes, he'll say, what is the risk? I'll say, let's say, I say there's a 2% chance. What exactly does the 2% chance of a bad outcome mean? Can any of you tell me what you understand? Supposing I say your chance of a bad outcome is 2%. What does it mean?
98% you're safe. 98 safe.
Yeah, but
low probability.
yeah, I mean, you're right in low probability, but basically what it means is if 100 individuals in the same circumstance as you come to me, 2 will go down, 98 will survive. Now, which 2 will go down, which 98, nobody can tell. Now, if you go down, for you it is 100%, no? You came, you went down 100%. So, it's very difficult how you explain that risk to a patient. So, when you say that if 100 patients like you come, only 2 or 3 will have a bad outcome, he feels better about it. So, but in today's world, if I don't tell that some outcome of bad is likely to happen, there's a chance that you will get sued also tomorrow. I mean, that is increasing. In fact, what's happening is, even if you explain that in this surgery, this kind of problem can happen, and that problem happens, he has signed that I'm okay for it, they're still going and suing. So, that is the bad side of how
Bad
medicine and society is developing.
Very true.
Nothing is given in writing that it can happen to you. So
Yeah.
just speaking verbally.
No, today
No, no.
nobody is taking consent just verbally. Everything is documented.
No, but when you try to convince the patient,
Mhm.
you always say this can happen, that can happen. All these things are just verbally.
No, there is written also, but every single word you say to explain can't be written.
Exactly.
But there'll be a gist written, which will list all the possible complications.
You will take signature before any surgery.
Yeah,
Absolutely.
definitely.
We take signature as anesthetists, surgeons take signature as surgeons.
True.
You sometimes hear, Subbu, that the physician comes into the picture after a surgery only after 24 hours, so the whole onus of liability or anything remains with the surgeon or the anesthetics for 24 hours after the surgery. Is that something true?
No, what do you mean by physician comes into picture?
Meaning whoever is going to treat you after you go to your room or whatever. But for 24 hours, you are basically, the responsibility lies with the surgeon and the anesthetist. Is that, I just want a understanding on that.
I'm not sure, still I'm understanding what your question is. See, when a patient is admitted for surgery, by and large, the patient is under the surgeon. He doesn't operate on behalf of a physician.
Okay, so the surgeon
Is the primary surgeon. Majority of the times, he may be referred by a physician. For example, a neurologist will see a patient and he picks up that there's a tumor. Then he'll tell a neurosurgeon, boss, I'm referring to you, operate this. Once he refers, the patient is under the neurosurgeon. So the surgery, now he's the neurosurgeon, I am the anesthesia doctor. We both do the procedure. I take a consent, he takes a consent. So then what is your question? If something happens?
The question is, something happens either on the table or 24 hours.
We are liable depending on what exactly. If there is, see, liability is if you didn't do what a normal doctor in normal circumstances in that country would have done. So that is the level of, I think Bharat will know. Yeah. So if you take 100 doctors in India, 90 would do what Subbu did, then Subbu is not wrong. So it's like that. It's easy for anyone. Today what happened is consumer court, at one time, if you had to sue somebody, you had to go to court, and if you're suing for 1 crore, you have to pay 10 lakhs as the court fee, 10%. Now in consumer court, they made it free. So it's become easy for everyone to go and allege whatever they want. Of course, you have to pay a lawyer fee, but it's become easy to, and a lot of frivolous litigation is coming up. There are lawyers who don't guide properly, and it's what should I say? It's a lot of, see, no doctors intends to harm a patient, and no doctors intends to be negligent. See, I don't deny there may be some commercial aspect in certain percentage of doctors, but all society in India is the same. There's corruption in all kinds of, you know, professions. So by and large, all doctors mean well. So if something goes wrong, it's despite your intention. So it is accidental. It's not intentional.
Doctor, you said that you will explain the complete case to the patient.
We will come to all questions later on. Let us finish the. Please, please.
Please carry on.
Subbu, I was told you also teach young doctors.
Yeah.
How does that happen?
Yeah. So that's again a good question. A lot of you don't know. So in medicine, training happens on the ground. So only in MBBS you sit in medical college with just classroom, just like any other engineering course or something. But from the third year of medicine, we go half day to the hospital and half day teaching. So after that, once you are in post graduation, 1 year internship is over, then post graduation